So this will be a webinar about the PSSC Schroth method, and you will get many more information about our approach and how we work with our patients. And here you can also see the official website of the method. You can find even more information. This is the website and the email from our clinic in Athens, Greece, and our social media. So feel free to go to the websites on the social media to follow our updates. I would like to first start this webinar by introducing a little bit myself to you. So for those that you're not familiar, I'm Nikos Karavidas. I'm a physiotherapist from Greece. I started my scoliosis education in 2012 when I did the SIAS course in Milan with Michele Romano and Stefano Negrini. In 2014, I was educated in Barcelona in BSPTS Rigo Concept School by Dr. Manuel Rigo. In 2018, in 2015, sorry, I got my certification in Schroth Best Practice by Dr. Hans Rudolf Weiss. 2018, in Germany, in Schroth International Schroth Scoliosis Treatment, ISST, by Axel Hens, and in 2020, in Lyon School by Dr. Jean-Claude Demarois. Since 2017, I started giving courses as BSPTS teacher, and during these 5 years, I gave more than 40 courses in Greece, Egypt, and Turkey. So getting all this education, and I'm really grateful that I had this education from great mentors, like all of them. I got my knowledge plus my own clinical experience, and I introduced new concepts initially in my clinical practice, but from 2022, developing the PSSC Schroth method and starting education with this new technique.
Ok, evo ukratko sumirano, da ako netko nije upoznat, znači ovo je fizioterapeut Nikos Karavidas koji je ukratko opisao svoj put sa Schroth metodom. 2014. godine, 2012. godine je započeo svoj put gdje je učio od Michele Romana i Stefana Negrinija. 2014. godine je završio Rigo koncept kod samog doktora Manuel Riga. Zatim je 2015. Godine učio od doktora Hans Rudolfa Weissa iz njemačke škole i nakon toga je u periodu od 5 godina do 2022. godine održao preko 40 tečajeva u područjima Turske i Grčke. I također 2020. godine je radio sa doktorom Jean-Claudeom u Lyonu.
Okay. So on this slide, I would like to explain to you the history of Schroth method. The so-called original Schroth method was developed by Katerina and Krista Schroth a little bit more than 100 years ago. And she was in use for many, many years until 2009. Some of the leaders of Schroth method, they worked together for many years, but for some reasons they decided to, let's say, develop their own ideas, their own philosophy. And since 2009, 3 different schools were created. The Schroth Best Practice by Hans Rudolf Weiss, the son of Krista Schroth and grandson of Katerina Schroth. Schroth ISST by Axel Hens, and BSPTS Rigo Concept by Manuel Rigo. So for those that you are familiar, you have done some education in one of these techniques, I will tell you the reality is that the so-called original Schroth method does not exist anymore. And I think it does not exist as a good evolution in the method because this was originally described many years ago, and by years, by experience, by new scientific evidence, of course, there are new data, new information, new techniques that started to be applied. So what is original Schroth method is not in use anymore, what was described by Katerina and Krista Schroth. There are now Schroth-based methods with different classifications and principles of correction, and PSSC Schroth, our school, is the latest addition in that field.
Što se tiče same Schroth metode, ukratko kroz povijest, originalna Schroth metoda započela je sa Katarinom Schroth i tada je to bila zapravo jedini način Schroth metode koji je bio aktualan sve do 2009. godine. Međutim, nakon toga razvijale su se različite verzije Schroth metode u kojoj je uključen i njen sin Hans Rudolf Weiss i zapravo s vremenom je razvijen i Rigo koncept za PSSC školu od doktora Manuel Riga. Što se tiče današnjih metoda, ako itko od vas upoznat sa različitim Schroth metodama, originalna metoda se više ne postoji, više se ne koristi zbog evolucije te metode, novih spoznaja, informacija i razvoja same tehnike. I sada zapravo postoje različite verzije Schroth metode sa različitim klasifikacijama. Nikos Karavidas je razvio znači PSSE-Schroth metodu.
Just to say something, because I have seen some of you raised your hand. Please, if you have any question to allow more time for the webinar, please write this on the question and answer section. There is a tab down or to your screen saying question and answers. So if you have any question or any comment, please type your question even in your language, if it is Serbian or Croatian, not in English, and we will have time to discuss about all these comments and questions. But we cannot, let's say, give you the word to speak each of you. So to have a good flow on this webinar, we have to manage on that way. So thank you in advance for that. If you have any comments or questions, please feel free to do that. Now, the term physiotherapeutic scoliosis-specific exercises is used to describe the curve pattern-specific exercises that are based on 3D autocorrection, patient education for activities of daily living, and stabilization of the corrected posture. It's not only Schroth method or Schroth-based methods that are described in the literature. We also have from other countries like Sias from Italy, Lyon from France, Dobomed and Fitch from Poland, Sideshift from United Kingdom, and now, lastly, we have also the PSSC Schroth from Greece.
PSSC označava vježbe koje su znači specifične za skoliozu i odnose se na vježbe koje su specifične i za sami oblik krivine. Bazirano je na 3D autokorekciji, također na edukaciji samog pacijenta za aktivnosti u svakodnevnom životu i također stabilizaciji same korigirane posture. Postoje znači različite verzije tih vježbi, ali PSSC Schroth metoda je specifična za Grčku.
There is a big discussion between some people about which method is approved or which method is the best or what Shosort says. So I thought that it is a good idea on this webinar to present to you what is the official Shosort board message for PSSC school. It is coming from the last SOSORT meeting in Belmore in Australia. So as you can see, SOSORT now says that there is no recommendation, support, partnership, approval, endorsement, or any favor of any individual clinic, product, service, process, or method. And I need to clarify this because some people, they say that there was a paper in 2016 describing 7 schools of scoliosis-specific exercises. But as SOSORT clarified, there is no approval from the SOSORT on any method. And I have to explain this because we are a new technique that was introduced to you almost 1 year ago. This does not mean that we have no approval or we are not valid or the certification that we give is not valid anywhere in the world. So just to have a clarification on that for everyone that participates in this meeting. SOSORT gives no approval but to any method, but insists that all PSSC schools should have some common characteristics that were described in the previous slide.
Što se tiče samog SOSORT-a, treba naglasiti da prema zadnjem kongresu iz Melbourna u Australiji prošle godine SOSORT se ne zalaže niti za jednu metodu na način da nema preferencije neke metode u odnosu na ostale.
So, our position as PSSC Schroth school is that the name of any school or a brace does not guarantee any successful treatment. So please, there is no need to fight about the names. This is also what SOSORT represents. No best school or method or brace. We have just different ways or concepts to treat the same condition, scoliosis. And my personal advice also as a school, we encourage all our students in our courses to do also other schools, other courses, and to learn as many as possible methods and to develop your own way of applying them to your patients. I personally couldn't say anything different because maybe one of the reasons that I am here in front of you tonight is that I followed many different educations to develop my own knowledge, getting my own experience to create what now is called as PSSC Schroth method.
Bitno je naglasiti da bilo koja škola ili vrsta ortoze neće sama za sebe garantirati uspješnost u liječenju, tako da bi se trebalo prestati zapravo rasprave o različitim imenima i deklaracijama, jer ne postoji najbolji način ili najbolja metoda. Nikosov konkretno savjet je da, kako je i on sam imao u svome putu, uzeti zapravo ideje iz različitih škola i različitih metoda i primijeniti ih na svoj individualni način za svakog pacijenta.
So, our concepts are acquired by clinical experience, and of course we are based on original Schroth principles as they were described by Krista and Katerina Schroth. We have got some adaptations from other schools based on my own education, and my idea on that was to try to keep what was an advantage in a school, so what was working very well, and to improve or to exclude any limitations that I found. Of course, in our school, as you will see in the next slides, we have a new curve type classification with a different philosophy, different criteria on how to classify, and some innovative ideas for 3D correction.
Njegova PSSE Schroth metoda je bazirana na nekim originalnim principima Schrotha, naravno poduprta je sa kliničkim iskustvom. Također uzeo je različite dijelove iz ostalih PSSE škola, zadržavajući njihove prednosti i poboljšavajući njihove limitacije. I tako je zapravo nastala nova klasifikacija prema tipu krivina sa inovativnim 3D korekcijama.
So on this slide, I'm not going to analyze, but just to give you an idea of other Schroth-based methods that they have their own way of classifying. So BSPTS has their own way, Schroth ISST, another classification, Schroth best practice, another classification based on different criteria. And of course, when you treat the patient based on the classification in these schools, you do different corrections. So obviously there are many similarities between all these techniques also, same with us, but also some significant differences on the way we apply the method.
Ovdje se mogu vidjeti različite klasifikacije Schroth metode koje zapravo imaju, ako možete primijetiti, dosta sličnosti, međutim razlikuje se sama primjena korekcije na pacijenta, ali generalno sve klasifikacije imaju iste neke osnovne elemente.
Okay. So for our classification, there are some advancements on the work that we have done. We have an easy and accurate way to classify by describing all curve types, answering only 3 simple questions. That's all. What you need to understand is to answer these 3 questions and you get the whole classification for our school. And I believe that for the classification is important to give not only, let's say, to divide the curves into different categories, but also to give the proper information to the therapist on how to accordingly treat their patients later on. Our classification is based on the decision to overcorrect or not. So this is the first time that is introduced the concept of overcorrection on how to classify your patient, plus or minus, you will see later. And of course, this decision is based on clinical, radiological, and prognostic criteria. The aim is to get the maximum of correction for care types that is recommended and to avoid compensations when this is risky. So in our classification, we try to avoid significant dilemmas. So when you are in a borderline on how to classify a patient when the curve types are balanced, thoracic and lumbar. So many schools, they force you from the beginning to decide if it is major thoracic or major lumbar. Sometimes easy decision, but sometimes really hard to decide. So why to put yourself in this dilemma? Or how to classify and treat patients that the pelvis is balanced, or when thoracic is, you are not sure if it is structural or not. Or another big problem when you have thoracolumbar curves and you don't know if this curve should be considered as thoracolumbar or thoracic, or if the apex can change. So all these problems that you probably have faced as therapists, in our school, we have very good solutions to avoid putting yourself in this difficult position to take a decision.
Što se tiče same klasifikacije ove metode, bitno je na jednostavan i točan način opisati svaki oblik krivine i to se može napraviti pomoću 3 jednostavnih pitanja koje trebaju biti odgovoreni. Prvo, bitno je dati dobre i točne informacije terapeutu kako znači liječiti pacijenta individualno. Također u ovoj školi je prvi put uveden koncept pretjerane korekcije gdje zapravo postoji odluka da li je ona potrebna ili ne, i ta odluka je bazirana na kliničkim kliničkim, radiološkim, ali i prognostičkim kriterijima koji su uzeti iz početne klasifikacije. Također, kada je potrebno i kada se preporučuje, treba se koristiti maksimalna korekcija za određene tipove krivine, međutim treba izbjeći kompenzacije kada je to previše riskantno, na primjer u slučaju duplih i balansiranih krivina. Također, treba se naglasiti da je bitno izbjegavati dileme kako klasificirati i tretirati tipove koji su balansirani. Nekada je jako teško to odrediti, radi li se torakalno ili lumbalno. Kod balansiranih krivina te Nikos navodi zašto bi se dovodili u takvu dilemu. Također, izbjegavati dileme oko toga kako klasificirati i liječiti tipove krivina kada je zdjelica skoro balansirana, kao i dileme kako klasificirati i liječiti tipove krivina kada nismo sigurni radi li se o strukturalnoj ili nestrukturalnoj torakalnoj krivini, kao i klasifikacija i liječenje torakolumbalne tipova krivine sa apeksom T12 L1.
So on this slide, we'll go one by one, these three questions that I explained to you, and you will see the algorithm that we have developed in our school to guide your thoughts on how you will classify your patient. So the first question that you need to answer to yourself is if we have a structural thoracic curve. So you have to do the forward bending test. Also, you can confirm later on the X-ray. And if your answer is yes, there is a structural thoracic curve, then you have to go to the second question. Where is the position of the pelvis in relation to the trunk in the frontal plane? Take care. The pelvis in the frontal plane can be either in the middle, on the left, or on the right. Or in other words, the pelvis can be on the thoracic concavity, on the thoracic convexity, or just in the middle. So when you have a structural thoracic scoliosis and the pelvis is shifted to the thoracic concavity, we have 3C type. When we have a structural thoracic scoliosis and the pelvis is shifted to the thoracic convexity, we have 4C type. When we have a structural thoracic scoliosis and the pelvis is balanced, we have non-3, non-4. And if your answer to the first question was no, there is no structural thoracic scoliosis, but there is a structural lumbar, we have SL, STL type, so single lumbar on single thoracolumbar. Better to translate to this point, Hannah, and then I can keep going forward.
Evo ovdje vidimo klasifikacijski algoritam, odnosno prvi dio gdje imamo ta glavna pitanja na koje je potrebno odgovoriti. Prvo pitanje je postoji li strukturna torakalna krivina. Tu ćemo koristiti test pretklona. Ako je odgovor na naše pitanje da, onda si postavljamo drugo glavno pitanje, a to je koja je pozicija zdjelice u odnosu na trup u frontalnoj ravnini. Zdjelica može biti postavljena u sredini, pomaknuta u lijevu ili u desnu stranu, odnosno može biti simetrična na strani torakalnog konkaviteta ili na strani torakalnog konveksiteta. Ako se zdjelica nalazi na strani torakalnog konkaviteta, onda se radi o 3C tipu krivine. Ako je na strani torakalnog konveksiteta, to je 4C tip, ili ako je zdjelica simetrična, taj tip se naziva niti 3, niti 4. Ako se vratimo na naše prvo pitanje i odgovor je bio ne, odnosno ne postoji strukturalna torakalna krivina, tada si postavljamo pod pitanje postoji li strukturalna lumbalna krivina ili torakolumbalna krivina. Ako je odgovor na to pitanje da, onda se radi o jednostranoj lumbalnoj ili jednostranoj torakolumbalnoj krivini.
And now we go to the most important advancement from our school, to the question number 3. Is overcorrection allowed for the main curve? when you have classified 3C and non-3, non-4, the main curve is considered to be the thoracic. When you have classified 4C or SLSTL, the main curve is the lumbar. And this question is very important because it will give you the idea on how to treat your patient later on. So when you say, yes, we can overcorrect the main curve based on some clinical, radiological, and prognostic criteria to take this decision. So you have to take all this information to analyze on your mind to take the best clinical decision for your patient. When you say yes, it means that we have the plus types. So 3C plus, 4C plus, non-3, non-4 plus, SLSTL plus. But if your answer is no, we cannot overcorrect, then we have the minus types. 3C minus, 4C minus, non-3, non-4 minus, and SLSTL minus. So in total, we have 8 different curve types in our school.
Sada najbitnije pitanje koje je specifično za ovu školu. Treće pitanje, je li pretjerana korekcija dozvoljena za glavnu krivinu? Kada smo ustanovili koji je tip glavne krivine, trebamo ustanoviti može li se postići pretjerana korekcija i to radimo prema skupno radiološkim, kliničkim i prognostičkim kriterijima. Samo treba koristiti zapravo sve tri grupe kriterija. Ako nam je odgovor da, tada se radi o 3C plus tipu, 4C plus tipu ili niti 3 niti 4 plus tipu ili eventualno jednostranoj lumbalnoj, odnosno jednostranoj torakolumbalnoj plus tipu. Ako nam je odgovor ne, u tom slučaju se radi o minus tipu.
Just to clarify something here, because my background is coming from BSPTS school, because I was a teacher for 5 years. And I have listened from some people saying that, oh, what Nikos and PSSC Schroth do at the moment is same to BSPTS. Just to clarify something based on our classification. In our classification, as you can see, in every curve type, we have plus and minus, which means that in every curve type, we can decide to overcorrect or not to overcorrect. Just for your own information, in BSPTS school, 3C type is always overcorrection. For us, as you can see, is not always overcorrection. And all the other curve types in BSPTS school, there is no overcorrection at all. But in us, we have 4C plus, we have non-3, non-4 plus, we have SLSTL plus. So we treat them, we treat our patients in a completely different way. Just to clarify, because I know my background is coming from this school, so some people, they think, okay, it's more or less the same. No, it's too far away what we do.
S obzirom da Nikos dolazi iz BSPTS škole, dosta ljudi mu je naglasilo da ne vide neku razliku u BSPTS konceptu i njegovom konceptu. Međutim, tu je jako bitno za naglasiti što se tiče pretjerane korekcije, da uz BSPTS školi 3C tip skolioze je uvijek dozvoljena pretjerana korekcija. Međutim, u PSSE Schroth metodi vidimo da može biti ili plus ili minus, odnosno može postojati pretjerana korekcija, ali i ne mora. Također u BSPTS školi za ostale tipove krivine nikada se ne radi pretjerana korekcija, a ovdje kao što vidimo ona može u određenim slučajevima biti prisutna, a u nekima se ne mora raditi.
So I believe that we don't just even develop, let's say, a different classification. Of course, this is one thing, but or different exercises, different application of the 3D correction. I think we have developed a completely different philosophy, and this is something that maybe it is introduced for the first time. So most of the other schools, they say either you overcorrect or you don't overcorrect. But for us, it's not just black and white always. So you can do what you will see later on as selective overcorrection. What does this mean? When, for example, you need to take a decision for the third question and to classify plus or minus based on if you want to overcorrect the main curve or not. If you say no, of course, is no. It means no other option. Forget about the word overcorrection during your exercises. But if you say yes, we still give you another opportunity to decide then how much overcorrection you need to do based on the curve type classification that you have and based on some other criteria. So it's not only you overcorrect or you don't overcorrect. You can say, yes, I overcorrect, but selectively. I will decide how much overcorrection I need. And this is the first time that something like that is introduced in a school of scoliosis specific exercises.
Što se tiče same pretjerane korekcije, u ovom pristupu iz PSSC Schroth metode nisu različite samo vježbe i pristup pacijentu, nego i sama klasifikacija ovisno o tome da li je potrebna pretjerana korekcija ili ne. I zapravo je uvedena cijela nova filozofija u vezi te teme. Ne mora se uvijek raditi o tome da se ili idemo na maksimalnu pretjeranu korekciju ili da nje uopće nema, odnosno Nikos naglašava da nije sve tako crno i bijelo, nego i postoji pojam selektivne pretjerane korekcije koja je bazirana na određenim kriterijima, odnosno na nama je da odlučimo u kojoj mjeri će biti zastupljena ta korekcija.
I think that I need to answer two of the questions that we have on question and answer section. So there is a question, what do I mean by overcorrection? I know this is very typical to ask me this thing and how it look on an X-ray or on the body. Overcorrection means to get the maximum effect of correction in an exercise for the major curve, for the curve that you decide. Of course, if you go to this maximum effect of correction, we usually get it by creating lateral flexion to the trunk. We accept that at some other parts, there should be a compensation. However, as I mentioned before, we do selective overcorrection. So we don't do in every curve type, in every exercise. We have some rules, some criteria that we follow in our school, and this is how we decide. So overcorrection means to get the maximum of correction for one curve, maybe most of the times by creating, as I said, the lateral flexion. So by the term overcorrection, we have overcorrective exercises that we allow lateral flexion, creating some compensations, but the only and one purpose for overcorrective exercises to get the maximum for the major curve. And we also have some overcorrective techniques that we use in other normal exercises, not the overcorrective ones.
Should we translate this or?
Maybe no need to translate this part. So just to clarify, of course, it is not possible for me to explain to you everything from a webinar. What do we mean by overcorrection? There are, as I said, some criteria, some rules that we follow, a new philosophy behind that. So I hope that this answer was okay, at least to cover some part of your question. And there is another question, what does the blue boxes mean below the yes or no buttons? So there is a question about this. Look, let's see an example. When you have classified 3C, so structural thoracic scoliosis, pelvis on the thoracic concavity, and you go to the last question, is overcorrection allowed? When you don't have a lumbar curve, or when the lumbar is minor compared to thoracic, so not significant, you can classify 3C plus, meaning that you can do some overcorrection for the thoracic scoliosis. If the lumbar was significant, then you should have classified minus, so no overcorrection. So in general, the idea here is when you have a clear major curve or just a single curve, it means that you can do overcorrection. When you have double and balanced scoliosis, please don't do overcorrection, because this compensation that will create is not good for the patient. Okay, so I think for the answers, for this answer, maybe no need to comment more on that, and I'm going forward. So on this slide, you can see all the classification that we have for 3C plus, 3C minus, 4C plus minus, and so on. And you can see the body image of the patient in standing and bending photo. We also have in our school, because it works for kyphosis as well, 3 different categories: thoracic kyphosis, thoracolumbar, and lumbar kyphosis. So the sign plus means overcorrection of the main curve in some or all exercises. The minus sign means no overcorrection for any curve in all exercises. And we also have the S type, defining the structural proximal thoracic scoliosis, where the apex is T5 and above.
Ovdje vidimo cijelu Schroth klasifikaciju prema Nikosu, sve tipove i također podtipove plus ili minus, ovisno o prisutnosti pretjerane korekcije ili bez nje. Vidimo pacijente u poziciji stajanja i također u pretklonu. Također, ova klasifikacija je primjenjiva i na kifozu, ovisno o tome postoji li torakalna, torakolumbalna ili lumbalna kifoza. Plus i minus, već smo rekli, označava pretjeranu korekciju ili odsutnost iste, i također postoji S, odnosno koje se odnosi na strukturalnu proksimalnu torakalnu skoliozu, koja označava apex T5 i više.
And here on this slide, you have all the classification, including also the X-ray. So all these types are treated based on some principles of correction that we have developed, many, as I said, new ideas on that. And this is our classification, let's say, a brief introduction to this.
Ovdje vidimo, osim prikaza kliničkih pacijenta, također i određene slike radiološki, prema kojima onda možemo naravno vidjeti je li potrebna pretjerana korekcija ili ne.
Okay. So let's come a little bit to our educational plan. So I guess that in the audience we have many physiotherapists that would probably like to think about getting this education. So I think it's good to give you some better idea on how we educate our therapists. So I think that we have chosen a proper duration, so not too short, not too long. So 9 days are enough to start applying the method in every curve type, and 15 days to get a final certification. On these 9 days, maybe the 3 out of them could be with a basic course, which is given online by live teaching on Zoom with an instructor. So 3 days out of the 9, you can still be at your home, no need to travel. And I think this is quite important nowadays. And of course, we have a high quality of theoretical education, clinical assessment, evaluation tools, prognosis, radiological measurements, pathomechanism of progression, a lot of things about the theoretical education for the basic course. And as an extra, for those that you are joining our education, you will get from the very beginning a unique patient evaluation form that is developed for clinical and radiological assessment of patients with scoliosis and kyphosis. Very detailed. You have all the information that you need to keep for monitoring your patient.
Što se tiče edukacijskog plana samoga tečaja, trajanje edukacije nije predugo, ali nije i prekratko. Traje 9 dana kako bi se počela primjenjivati metoda na svaki tip krivine, a 15 dana je za konkretni certifikaciju. 3 dana od početnih 9 je basic online tečaj, uključujući instruktora na Zoomu, tako da za ta 3 početna dana se može biti još doma, nema potrebe za putovanje. Također, sami tečaj uključuje veliki raspon teorijske edukacije i znanja. Osim kliničke procjene i same prognoze, sagledavat će se znači i radiološke mjere, sami patomehanizam nastanka skolioze i njene progresije i ostalo. I također za svakog pacijenta, bilo sa skoliozom ili kifozom, će se primjenjivati individualni pristup, kako klinički, tako i radiološki.
I'm not going to explain all this, but here you can have an idea about the whole educational plan. So to start applying the method, you have to attend the basic and the level 1 course. The basic is about clinical radiological assessment and theoretical education. The level 1 is the practical part, when you are educated about applying the exercises with your patients. So to that point, you are certified and able to start applying the technique. Then your final certification in our school is coming after the level 2 course, when we have advanced exercises, practice every day with real patient under supervision, case-based analysis for treatment decision and practical approach. So a lot of information about brace. And there is also another optional course for those that they would like to expand even more their knowledge.
Ovdje se detaljnije vidi malo o edukacijskom planu. Kako bi počeli primjenjivati samu tehniku, potrebno je završiti osnovni tečaj, odnosno basic kurs i također level 1. Level 1 je praktični dio i nakon toga se primjenjuje sama tehnika. Također za finalnu certifikaciju ove Schroth metode potrebno je završiti i level 2, tečaj koji traje 6 dana i ovdje se rade se naprednije vježbe za kifozu i za skoliozu i svaki dan se vježba sa pravim pacijentima, naravno pod supervizijom samog instruktora, i također se radi analiza bazirana na svakom pojedinačnom slučaju. Također postoji i tečaj koji se može napraviti ili ne mora, koji traje 4 dana za one koji bi htjeli još detaljnije upotpuniti svoje znanje.
In our school, it's not only me. Of course, obviously, I'm the founder of the school, but we have already created in less than 15 months that we officially started a great team around me. So we have already 13 instructors for our school. Dariusz Czaprowski and Lukasz Stolinski from Poland, Yavuz Yakut, Merve Karatel and Bursin Şerintürk from Turkey, Georgiana Koyokaru and Larissa Jacob from Romania, Sara Mohamed Ali from Egypt, Silvio Solfo from Albania, Alexander Perkun from Russia, Marie-Louise Smits and Gabriela Kasansky from Netherlands, and Firas Wabe from Syria. So I'm happy and proud to have all these instructors in our team, and we are still growing and expanding our school. And we're just on the first year.
Evo već u prvoj godini razvoja ove škole za sad postoji 13 instruktora iz različitih dijelova svijeta i naravno sami tim i dalje raste.
Okay. And even though we are quite new school, I can tell you that we already teach in 14 different countries: Greece, Turkey, Romania, Egypt, Netherlands, Russia, United Arab Emirates, Albania, Poland, Saudi Arabia, India, Kazakhstan, North Macedonia, and very soon in Croatia. And we're also in discussion, and very soon we'll announce our courses to China, USA, Canada, Brazil, Australia, and many other countries are coming soon.
Edukacija je, znači postoji u različitim dijelovima svijeta i državama, nije samo u Grčkoj, vidimo da je i Hrvatska ovdje na popisu, a uskoro će se proširiti i na Kinu, Ameriku, Kanadu, Brazil i Australiju.
I need to answer some of the questions on the chat. So there is a question by Amr. Is it going to be in Syria? Yes, we hope so. We hope that very soon we'll be there, not only in Syria, but also in nearby countries. We are working on this part with our instructor, Firas Wabe. And I think that it will be very good and important for the local people to get a higher quality of treatment. So yes, hopefully very soon we will be also there. Stay tuned. And there is also another question by Xiaochu Chang. How to differentiate between minor thoracolumbar and with significant lumbar in 3C types? Does it depend on the Cobb angle difference? So if I correctly understood, your question is how you decide if this is minor or significant. So we have some criteria: clinical, radiological, and prognostic. Clinical criteria are the trunk rotation, the body symmetry, so the frontal plane imbalance. Radiological criteria, of course, one main is the Cobb angle, but not the only. Vertebra deformity, vertebra rotation, growth stage, the curve type that you treat. And of course, we have prognostic criteria like pain. Of course, we also take into account if there is a structural proximal thoracic. So as I usually like to say, we have many different information. And I always believe that the information is out there. It is how you receive the information and then how you interpret the information you take from the patient. And believe me, for those that you will attend our courses in the future, you will understand how many information you can take from clinical and radiological evaluation of the patient. So then you gather all this information together, you make a synthesis on your mind to take the best clinical decision for your patient. So this is the plan in general. I hope this is okay as an answer. At the time that I opened this slide, I saw many comments. If you are coming to Algeria, if you are coming to Kuwait or any other countries, yeah, I hope that very soon we will reach even more countries. There is already a huge demand, to be honest. This is why I'm very happy that I'm not just alone in my school, but I have 13 wonderful instructors around me. So sooner or later, I think that will probably be also in the countries that you asked me. Maybe we have, I don't know, some fans from Algeria because Algeria is there. Okay. So hopefully will be to every of these countries. There is a question, maybe we need a translation. So if you go to question and
Yes,
answers, Hannah, can you translate me because
yes.
I
There
don't
was a
know.
question if the certificate is approved in Switzerland, and also what is the price of the course?
All right, I will tell you. The certification that we give is approved all over the world. So the educational protocol that we have is the same all over the world. The language is changing or the instructor, but no other difference. So of course it is valid everywhere. For the price of the course, it depends on the local circumstances. So I would advise you to go on our website, www.schrothpssc.com, and then you will find more information, and then you can directly contact the local organizer or the instructor. Some other questions to answer. Is there any contraindication to implement PSSE Schroth method? No, there is no contraindication except general contraindications, for example, to apply scoliosis-specific exercises. So just to give you an example, if you have a scoliosis coming by a tumor, of course, don't think about working with scoliosis-specific exercises, okay? So no contraindication, of course, no problem. Older people, yeah, of course, or only children. No, of course. And be patient. If you stay to the end of this webinar, you will see the last part is about some of the results from our school. So you will have a lot of information on how we can improve also adult scoliosis. So definitely we work also with adults. Brace types suitable for our school. I will tell you, this is an ongoing work. You will see also some data that have already been published applying our classification to brace design, and it works very well. You will see the results later. So of course, we will also develop, hopefully in the future, a course for orthotists as well, not only for physiotherapists, but we need time for that. Okay, Firas, you are welcome to Algeria. All right. Have you done research on the effectiveness of your program? Yes, of course. Please be patient. If you stay later to this webinar, you will see what is published so far. And of course, we are a school that we just introduced last year, of course. So we need time. However, I can tell you from my own experience that for me, it's not something new. So for those that they believe, okay, Nikos decided suddenly one day to develop his own method. No, this is not true at all, because although I was teaching for another school, in my clinical practice, I have already implemented all my ideas. And believe me, I have seen that it works very well. So you will see some of the results, also some of our publications in a while. And I think we answered all these questions, except one that I need some translation again from you.
I will just translate the first question if they maybe didn't understand it, and then I will translate this one.
Okay.
Što se tiče prethodnog pitanja u vezi Švicarske, ovaj tečaj, odnosno sami certifikat se priznaje u cijelome svijetu, a sama cijena tečaja ovisi zapravo o samoj državi i stanju u državi, i to sve možete dobiti informacije na njihovoj web stranici www.PSSE-Schroth.com. Okay, and this question now, they're asking if this technique can be applied to children with cerebral palsy that are mentally preserved.
Okay, thank you for this nice question. I will tell you what is our aim. Very soon, I think that we will be in a very pleasant position to announce that we have a specific protocol and program of exercises for neuromuscular scoliosis. We are already in the process of developing this, because in our group, we have some very experienced pediatric physiotherapists working with neuromuscular scoliosis for many years. And I think that it is something that is generally missing. So I can see Alma is laughing. Be patient, Alma. We have plans also for this. but we need time to provide a good protocol. But I think is important because many times when you have not only cerebral palsy, but other neurological conditions associated with scoliosis, you need to have a good plan and a good protocol. So this is also something that we'll do. Okay. I think we need to move forward and then we can come back to some of the questions. So please feel free to ask your questions, but I need to go forward. Now, for the practical application of our method, the idea is to treat our patients precisely and safely to get the maximum effect of exercises based on their curve type. We have introduced some innovative concepts of correction, new terminology with perfect accuracy on describing body blocks and concepts of correction, new ideas for corrective rotational breathing, new techniques for muscle activation, concepts of ADL training based on our classification, new exercises or different execution of already existing Schroth exercises, new ideas for mobilization, and we are a school that we combine a lot corrective breathing with mobilizations. You will see I have some short videos for you just for a demonstration. And we pay special attention on proximal thoracic scoliosis and thoracolumbar curves. Try to be brief. This is a long slide, Hannah, so just be brief on that.
Quick.
Yeah.
Evo, ukratko što se tiče samog praktičnog dijela, naravno želi se postići maksimalni učinak pri liječenju samog pacijenta. Osim 3D koncepta korekcije, bitno je zapravo implementirati nove ideje za korektivno i rotacijsko disanje. Također se bazira i na aktivaciji mišića i zapravo kako bi pacijent sve to mogao implementirati u svakodnevni život. Također poseban je naglasak na novim konceptima korekcije za proksimalnu torakalnu skoliozu i za torakolumbalne tipove.
Okay. These are in general the principles of correction that we have in our school. So we have 3D autocorrection, including self-elongation, pelvic corrections, corrections of the frontal, sagittal, and transversal plane, corrective or rotational breathing, muscle activation in the corrected posture, and stabilization. So just to give you an idea on how it works, the first thing is to bring everything into the perfect 3D correction, then to, of course, improve the correction by the corrective or rotational breathing, expand the collapsed areas, and we activate in correction. We also work a lot with the mobilizations while the patient is in correction while exhaling. And stabilization is the last phase. So how the patient is able to keep the correction after the exercise and to implement this into activities of daily living.
Što se tiče samih 3D principa korekcije, prvo je najbitnije napraviti 3D autokorekciju koju zatim treba poboljšati i pojačati sa korektivnim, odnosno rotacijskim disanjem pri udahu i izdahu, gdje postoje 3D ekspanzijske tehnike za kolabirana područja, a u izdisaju održati ekspanziju. Naravno, bitno je aktivirati mišiće, gdje se puno radi i na mobilizaciji i za kraj stabilizacija u samim aktivnostima svakodnevnog života.
So we have to correct the scoliotic posture during the exercises and to educate the patient how to unload the spine during daily life activities. So how to sit, how to stand, how to sleep, which side, what to avoid, everything related to normal daily life activities.
Ovdje vidimo razliku između skoliotične posture i korektivne posture i bitno je da pacijent zapravo nauči koja je njegova korektivna postura i razlike u odnosu na skoliotičnu posturu kako bi mogao zapravo se stabilizirati u korekciji tijekom svakodnevnih aktivnosti njegovog života, spavanja, sjedenja i svega ostalog.
So now you will see on the next slides, I have prepared some videos for you. Just let me know first if you listen to the audio of the video. Do you listen? do you listen the audio of the video?
Would you try again? I can't hear it.
No, all right. Let me go back. I think that to listen to this, I need to remove my AirPods. So let me know if you listen the video.
And while you breathe out, I can mobilize the ventral. And while you breathe out, I can mobilize.
Perfect. Okay. So this is one of the exercises that we use. You asked me before about overcorrection. So this is an overcorrective exercise. It's an overcorrective exercise for a right thoracic scoliosis. So it means that we bring to the maximum of correction the main curve. We call it selective overcorrection because we decide how much we need to do, how many days per week, how many sets, how frequently. And as you will see also in this exercise, but also in some of the next slides, corrective breathing is combined with curve pattern specific mobilizations. So I think no need to translate something for this part. It's just the video to play, okay?
The ventral lip count, dorsal cranial and lateral to this direction. Breathe in, open, mobilize. Don't do that. Keep that. Mobilize to this direction. If I want to make it a little bit easier from here, I can fix the ball with my legs. Breathe in, open, breathe out. Also, you can have this mobilization. Look, with your hand on the thoracic cam, ventral medial, fixing the shoulder. But you need, breathe in, to change always the position of your hands. And breathe out.
So this is one example of how we work. There is a question, is mobilization active or passive? The mobilization, that's a very nice question because you give me a nice pass to give you a good answer. So mobilization is passive, is done by the physiotherapist. But if you do it properly and in combination with the corrective breathing, there is not only the effect of getting better range of motion in a rigid area to improve flexibility. Obviously, this is one thing. But the way we use the mobilizations in our school is into the corrective direction on the prominent areas. So at the same time you mobilize, you give better correction because you do it during the exercise, and you give also a feedback, a proprioceptive input to the patient for the corrective direction of the prominent area. So this is why in our school we combine this a lot, and you will see some other examples in a while, okay? So this is another exercise. We try to do precise corrections and to get the maximum of muscle activation. So these videos are taken from the course that I give these days. Is the first course that I give in Dubai. So
Stay there.
take a look.
Don't fall down with the ribs. Head a little bit more back. Don't kyphotize the neck. Look, don't kyphotize the neck. That's it. Keep this up, elongated, extend the knee, lock the knee. So these lines should be perfectly straight. Okay, and now we can work. Breathe in, open, and breathe out. Push the palm to the floor, and we can also use some pressure here to keep this up and raise the leg from the stool.
So this is another exercise. Please don't think that you take this exercise and you work with any scoliosis patient. Don't do that. It's just a demonstration, but is specific way to correct based on the curve type and the classification that we have.
Stay there.
Of course, we want to have accuracy of the corrective breathing and 3D correction based on what we call as visualization of the body blocks. So this is another concept that is first time introduced by our school, and we pay a lot of attention to understand how much space each block takes on the patient body. Because if you want to be precise and accurate with your corrections, you have to do that in every single patient that you treat. And we have also tried to improve some already existed Schroth exercises. And here you can have an example on the ball.
Yeah.
more, to be more elongated, not keep it down, your head a little bit more up.
Straight. Just
Good.
good.
Now, the way you get the elongation is this. So pulling the pelvis back. You have to be perfectly straight in this position, maybe some retroversion, abduction of the other side leg. This should be bent, and then you can work with your weak side, weak point, breathe in, open, and while you breathe out, you push the leg to the front.
Okay.
We have also introduced new curve pattern specific exercises and new techniques for mobilization. Like you can take an idea on side lying
It's
on
a
this
very
side.
nice way to mobilize. That's- Let's do it. Breathing, open. And while she breathes out, I bring my hand from ventral flat zone to ventral rib hump. And my hand from weak side to L side shoulder. I bring L side shoulder up with here. Up means we open more the weak side. Forward, the L side shoulder. We need to bring it forward. And I can fix my pelvis with my elbow and my thighs, mobilizing the ventral rib hump back. So
This is another example of combination of corrective breathing with specific mobilizations during exhalation.
use a very
And of course, we have advanced exercises, advanced mobilization, really a big variety. Take a look also on this example, just to give you an idea. I know it's just theoretical, it's just a webinar, but at least you can have an idea on what we work in our courses and how we approach our patients.
stay there. Okay. Second pelvis correction. Good. Don't forget the head should be always well aligned. When positioning your head, you can also keep the shoulders out in this way. And then breathe in, open, expand. And while you breathe out, you can, of course, keep your hands here to say, keep the expansion, but you can change to help a little bit the short hanging. Remember, in every exhalation, you pull the bar down, head up, pelvis down. So breathe in, open, and while you breathe out, you pull the bar down, keep your head up, and look, with my elbow, or this part of my elbow, I can mobilize here forward. So breathe in, open, and breathe out. I can help the short hanging, but also
to mobilize. This was the last part of this video. So this is also a new kind of mobilization that we use for kyphosis. This is an example for kyphosis, not for scoliosis. So before I go to this slide, let me answer the two questions that I see. There is a question about any exercises within the brace. So there is also a part of what we do with our patients, so we can train them, especially we work a lot with the corrective breathing, but this is not something that I can demonstrate to you now. However, the vast majority of the exercises that we do are without the brace. But with a good quality of brace, with a good design, the brace should be compatible with what we do. For example, the areas that we need to mobilize, so the prominences, should be the pressure zones in the brace. The areas that we need to use our hands to expand the collapsed areas should be the zones of not having any pressure, the expansion rooms in the brace. So, of course, then, as I said, what we do is absolutely compatible with the brace, and we have developed our classification also for brace design, and this is, again, another ongoing work from our school. There is another question, is it useful to use a mirror for self-correction? Absolutely. So always we have mirrors in front of the patients or on the side of the patients based on the exercise that you do, because the visual feedback is something that helps the patient to compare the scoliotic posture with the corrected posture. Okay, so please use a mirror. It is very useful. Our exercise is uniform for all ages after puberty and also for ages before puberty. Look, of course, the exercises should be applied based on the patient needs and also the patient ability to perform them. So when you have a very young patient, of course, you have to modify your program in a way to make it feasible for them to do it. And we simplify, let's say, in some way. So in our school, we can start working at a very young age. maybe even less than 7 or 8 years old. So we can start working. When we speak for elderly people, so for older adults, of course, then you have to modify. So you get all this information from our education on how to apply based on these criteria for specific categories of patients. There is also another question that we didn't answer in your language, so please, may I have a translation?
Yes, they're asking if it is possible to organize the course over the weekend or maybe privately.
No, I mean, you mean over a weekend. The educational protocol for us is 3 days for the basic course, and the basic is online. So you can stay at your home and you can attend the basic online course, getting a high quality of education. But for the level 1, of course, we cannot do online, okay? And based on my experience as a teacher for a school, I can tell you that this was a complete fail and my strong disagreement with the way that some of the courses were performed in the past, online practical courses. Online practical is not possible, unfortunately, okay? So we cannot do that. We cannot split the course only in weekends because for a local person is okay. I mean, let's say I live in Athens in Greece. So if I say that these 9 days will be split in 5 weekends, is okay for the local people, but for someone traveling from away is not possible. So this is the way that we manage at the moment. 3 days online, then 6 days in person, okay? Perfect. So now, you asked me some questions before about the scientific data and what we have provided so far. And here you can see one of the results that was presented by me for the last social meeting in Melbourne, Australia, 2023. And it was in the award session. So we used PSSC Schroth exercises in 221 patients and no, in 163, this was the total sample. And we compare it with a control group that they did general or no exercises. So what we found was that in 87.1% of our patients, there was no progression. And this is one of the highest success rate that have been described in the literature. This study is in the last stage of review process for being published. So I hope that in the next months, you will have the official publication of this study. And also we got a significantly less brace prescription rate. So in all this group that we had patients 15 to 25 degrees, peak of growth, more than 5 degrees with the scoliometer, less than 1 year post-menarche, we got only 10% of them that they finally needed a brace. So it means that the application of PSSC Schroth exercises is effective to reduce the risk of progression at the peak of growth in mild scoliosis. And we also got a significant improvement of trunk rotation, body symmetry, and quality of life. I think no need to translate this part, Hannah, because it's a study, a publication. You have here the information, and I hope that very soon you will also get the official publication. This is a study that is published again from our school, and it is a combination of PSSC Schroth exercises with a brace, and the brace design was based on our classification. So in this study, we had 102 patients at the peak of growth, so high risk for progression for them, and we got a success rate of 88.5%. Again, one of the highest in the published literature, and only 6% passed above 40 degrees in this group of high risk for progression. So it seems that a combination of a brace design based on our classification plus PSSC Schroth exercises can effectively treat scoliosis at the riskiest period during the peak of growth. Okay, so these are some of the data. Of course, there are other studies that are coming up, but please, you have to understand that we introduced this school just 1 year ago. It's just 15 months. So I think for 15 months, the fact that we are already 13 instructors teaching in approximately 15 countries, giving courses almost every week now, having already 2 publications, I think is okay for 1 year. We have a lot of time in front of us to provide even more strong scientific evidence and even better results, but you will see on the next slide some of the results that we have got so far. Okay. Let's answer some of the questions. So there is a question if our theory is registered with the National Federation of Physical Therapy. I don't understand the meaning of this question, to be honest. How do you mean to register our theory with the International Federation of Physical Therapy? I don't know what you mean. However, I cannot give you a good answer on that. What we do does not need any registration with Federation of Physiotherapy. It's just a physiotherapeutic method. So there is no, let's say, organization that we need to register to be valid to give certification, not only for our school, but for every PSSC school. There is no federation, there is no organization to apply for that. Okay, I hope this is a good answer for you. And there is another question, are there any explanation for this 12.9% where the curve progression happened? You mean which curve progressed? If you mean which curve progressed, I can give you some information that it seems that in double curves, double scoliosis, the percentage of progression was higher compared to single curves. And I think it makes sense. A single curve can be more easily treated. If your question is related to if most of these people that had progression were thoracic or lumbar, I can tell you this was equal, but I can also give you an extra information. This 12.9 in the previous study or 11.5 in this study included all the participants, also those that were not compliant with the treatment protocol, because we did a separate analysis for those that they were compliant with the treatment protocol, either only exercises in the previous study or brace and exercises in this study, and the success rate was up to 95% in this case. So, of course, it seems that one of the most important prognostic factors is the compliance. Okay, I don't see any other questions so far, so better to move forward. And now you will see some of the results coming from our school, from our method. Here you have a patient, we had a patient with 20 degrees of scoliosis, still growing. And in these cases, of course, the main aim is to stop progression and avoid or delay bracing. This is always, let's say, the first aim. However, in this case, what we got was a reduction of the curve from 20 to 7 degrees in 1 year. I think also for these slides, maybe no need for translation, Hannah, because they are just the pictures. So
Yes.
if any of the participants have some questions, of course, when we finish this part, this is the last part of the webinar, and then we have plenty of time to go for a discussion, comments, questions, whatever. Okay. This is another example with 23 degrees of scoliosis. This patient was recommended to wear a brace, and we started only with exercises. We aimed to stop progression, but we got also significant improvement on this curve. So as you can see, there are patients that we work only with exercises as an exclusive treatment in case that we have a mild scoliosis. In this case, we had 25 degrees left thoracolumbar scoliosis, and we got a significant reduction to 10 degrees. And you can also see the very significant improvement on the patient body balance and also on the trunk rotation, also in the vertebra rotation when you compare the X-rays. So when we have patients at a later growth stage, like this one, even above 25 degrees, you can still work only with exercises. And the aim for this category of patients is to avoid bracing, to improve body balance and aesthetics, and to reduce the potential for long-term progression. This is another example, a double scoliosis treated only with exercises. She was 31 degrees thoracic, 34 degrees lumbar. She was treated only with exercises because at that time she was at reserve 4, so to a later growth stage. And in this patient, we reduced the curve from 34 to 20 and from 31 to 22. And you can also see the significant improvement on the body, on the body symmetry and also on the trunk rotation. Because it is important for them, not only the radiological improvement, but mainly for most of them, it could be the body balance and aesthetics. This is another patient, again, 30 degrees, reserve 4, with the left thoracolumbar, right thoracic curve, 30 degrees, and we reduced the scoliosis from 30 to 13 degrees, so 17 degrees of improvement. And you can also see the improvement on the body balance of the patient, the trunk rotation, and take a look also for those that you are familiar with the measurement of vertebra rotation. You can see the significant improvement of the vertebra rotation, not only the trunk rotation. So it means that we can achieve to get a very nice correction also in radiological terms. You can see the position of the pedicles on this X-ray and the position of the pedicles in the next one. And these patients that you have seen so far were treated only with exercises, no brace treatment for them, okay? You asked me about adults. Now you will see some examples for adult scoliosis. The aims for our exercises are to improve aesthetics and pain, especially when we speak about young adults. The clinical image is one of the most important reasons why they come to us. Many times they come also with pain. And we also aim for the long term to reduce the potential for progression. And when you speak about scoliosis more than 40 degrees, to avoid the risk of undertaking an operation. So in this case, we got a reduction from 41 to 36, but look, not only on the X-ray, but also on the body image, a significant improvement on the patient balance, on the pelvis, on the shoulders, and also the significant improvement of the rotation. This is another example of adult patient starting from 53 degrees. So you see that I have included in this presentation not really small curves, but some really rigid, difficult scoliosis with a surgical indication, some of them. And in this case, we improved the cob angle, but also a very significant improvement. If you take a look on the photos on the body image of the patient, and again, if you see on the position of the pedicles before and after the exercises, you can see a very nice reduction of the vertebra rotation. So, except for those that we treat only with exercises, obviously, when we have a brace indication during growth, we have to use a combined treatment with brace and PSSC Schroth exercises. So the brace is designed based on our classification, and you can see in this case, we started with 32 and 33 degrees at research 0, so a double scoliosis with significant imbalance and rotation. And this was the result 2 years later. This X-ray is taken 48 hours without the brace. And you see that we reduced the curve from 38 to 8 degrees and from 32 to 16. So more than 50% of improvement in the cob angle. In these cases, when we speak about young adolescents during growth with curves more than 30 degrees, the aim is to avoid progression, to, of course, enhance the brace result, and with less brace wearing time. That's really important for the patient. So I can tell you that when you combine brace with scoliosis-specific exercises, you can probably get even better result than brace alone with more hours. And for the patient, it's really important to get the best possible treatment result with the less effort, less brace wearing time. Of course, to avoid progression going to the surgical indication range and to improve aesthetics. And you can see a very nice result on this patient. Another one, double scoliosis, 30 and 36 degrees. Look, the in-brace X-ray, we know that the in-brace X-ray is, the in-brace correction is one of the main prognostic factors. And we usually say that you need to have a 30% of correction in the brace to say that the brace is effectively correct the curve. And you can see in this case, for the lumbar, we got almost 100% of correction and over 60 or 70% of correction for the thoracic. This patient was compliant with brace and exercises, and the end result was to reduce her scoliosis from 30 to 16 and from 36 to 23. Also, very good improvement in clinical image of the patient. But we work also with brace and exercises, not only in scoliosis below 40 degrees. And this is also a study that is presented in the last SOSORT meeting, and it is going to be presented in the next SRS meeting in San Diego in 2 months, combining from our school brace with scoliosis-specific exercises with our method for curves only above 40 degrees. So important, we treated curves with a surgical indication, okay? And as you can see in this case, from 45, we reduced to 34 degrees, having an excellent improvement also on the body image of the patient. And obviously, in these cases that we have more than 40 degrees, we can give them, let's say, an alternative option. It's not only the operation, the option for them. Take a look on another example. From 48 degrees, we went down to 39. Look the body balance. Look the thoracic hump before treatment and after treatment. This was the in-brace X-ray, so 50% of correction in the brace. This is another, even more, from 65 down to 47 degrees with a very significant improvement of the body image. So, of course, we can get very good results when we combine brace and PSSE-Schroth exercises, but we can also work in combination with operation. And I think this is a part that we need also to work a lot in the future if we want to attract more attention from the surgeons. So many times the surgeons, they decide to do selective thoracic fusion, meaning that they try to save levels in the lumbar, not to be fused, to avoid long-term complications and to allow better mobility for the patient. So if this is the choice of the doctor, of course, we can work with PSSE-Schroth exercises to stabilize the secondary curve, to save levels of fusion in lumbar spine, and to improve body balance in aesthetics. Another option for operative treatment could be non-fusion operation combined with PSSE-Schroth exercises, like with the ApiFix system or the vertebral body tethering that is becoming more and more popular among surgeons. In this case, the aims that we have is to provide further correction postoperatively, to enhance growth modulation, because these are techniques that work with growth modulation. So they stop the growth on the convexity, they enhance the growth on the concavity, and the way we work with our exercises can help that and improve body balance and aesthetics. And we can also work with, this is, let's say, maybe one of the most recent techniques that is developed by the orthopedic surgeons, a hybrid surgery. So selective thoracic fusion with a lumbar vertebral body tethering. This is the first patient that I treated in my clinic with this combined approach. So in this case, of course, we aim to get further correction, enhance growth modulation, save levels of fusion for the lumbar spine, and improve body balance and aesthetics. And from my own experience that I have been working for a long time also with surgeons, I can tell you that the surgeons, they have started paying more attention on what we do. And I can tell you this because I'm in these conferences also active Scoliosis Research Society member, Eurospine program committee member, SOSORT Scientific Society member. So I can tell you that the international scientific societies, they pay more and more attention on the work that we do. So it is on our hands to prove that what we can offer to the patients, also when we speak about operative treatment, before or after operation, is again very important. So in our school, we have developed also protocols on how to approach this, because I have quite good experience working with patients before or after operation. So this is another great advantage for those that you decide finally to come to our school to get your education. So this is the end of my presentation. So now we still have approximately 20-25 minutes for those that you would like to stay with us. And I can see we have already many questions to be answered. So let's go one by one to them. And feel free to ask if you have more questions. So there is a question. If the surgery was performed and the result was not that good, is it possible to do the same PSSC exercises again? That is a general question. So we have to understand the exact type of operation, the patient that you have in front of you to give you a good answer. However, I can tell you that if the result is not good, of course, you can offer something to them, but you have to understand where the limits are. So unfortunately, some patients has come to me after a failed operation, and I said, unfortunately, I cannot offer you anything. So it depends on what you mean. The surgery didn't go well. Okay. I cannot give you a very good answer because it's always something that you have to individually assess. There is another question. This improvement were after how many sessions? So in most of the cases, you show also the date. So in some of them, this was 1 year, in some other was 2 years. So it's not just after 1, 2, or 3 sessions. So to get a permanent result, because you can see a temporary result just after 1 or 2 sessions, but to get a permanent result that can be maintained in the long term, it means that you need more sessions and you need more time on that. But I can tell you from what we have seen in our school and based on my education and experience, you can see from maybe the first weeks, you can see an improvement on the patient. But to maintain in the long term, there is a lot of work to be done. And again, it's something that is really individualized. So in some cases, you can get sooner. In some cases, you need more time. There is another question by Victoria. As many children come to us with scoliosis and also knee or and feet problems, also muscle imbalance like in leg length discrepancy. Do you give special attention during your program about these issues when they affect the posture? Victoria, thank you for the nice question, because this is very typical in level 1 that many of our students, they are asking about leg length discrepancy. I can tell you we are the only school that we have a lecture of approximately 2 hours in level 2 course speaking about leg length discrepancy, because when you have a true leg length discrepancy or just general leg length discrepancy, you need to analyze many things. It's not just you have one leg taller, you put a shoe lift. No, it's completely different. So you need to analyze a lot of things, also the curve type to think about prognosis, how this true leg length discrepancy can affect the prognosis of the patient. And sometimes I can tell you, you have to intervene, some others not to intervene. But if you decide to intervene, again, you need a clinical monitoring, follow-up of the patient to see if your clinical decision to use a shoe lift was finally good or not good. So that's a very big issue to be analyzed now, but of course, we pay a lot of attention. I can tell you much more than any other school. There is another question. Would you recommend attending this course for physiotherapists who work with children who have SMA, spina bifida, in general, children with neuromuscular or neurodevelopmental diseases, or not yet, as you haven't developed this course in the direction? No, I would advise you to come and attend the course as it is now. I can tell you from my experience all these years, almost in every course, there is a pediatric neuromuscular physiotherapist that attend the course. And many physiotherapists that they follow like BOBATH or PNF or techniques like that. Some of them, they are also teachers in their field that they come to our course. And what they feel is that all these techniques, they have a limit. When you have to do something really specific for scoliosis, you cannot get the best that you can. So all these techniques are really helpful in general, but not specialized in scoliosis treatment. So even when you come to the course as it is now, you will get a lot of information and a lot of skills that you can apply with your patients even from now. But I think this is a very big topic to be just included in what we do with adolescent idiopathic scoliosis, because many other things that you need to take into account. So we pay attention also on this. We have from the basic course some introduction to neuromuscular scoliosis. Not other schools, they have this education. But yeah, hopefully in the future we can make something even, let's say, more specialized on that field. I will leave the questions that we need translation to be the last. Okay, so I'm keep going with the other ones. Could the aesthetic be improved without improving the curvature? Yes, it is possible. It can happen. So let me show you a good example. Okay. I can share with you like hundreds of good examples, but take a look on this to answer your question. You see, the angle is the same, 61 degrees, but stabilizing this curve with 61 degrees of lumbar at research 0, first diagnosis with a very rapid progression is an excellent treatment result. However, the angle is the same, but what do you think? Is there an improvement? Obviously, a very significant improvement of this patient. So you have to understand that the angle is just one parameter to be analyzed, but maybe not the most important thing even for the patient, because this patient is extremely happy with this significant improvement on her body. And of course, if you explain everything well from the beginning to the patient, they will understand that the angle is something that the main aim is to be stabilized. Okay. Of course, you can get some reduction. So I hope this example is a perfect fit to answer your question. You are a physiotherapist from Algeria, time for each exercise. Okay. Too many people from Algeria. All right. I hope we will be there soon for you guys. What type of brace they wear? The brace that they wear is an asymmetric CNOT type brace based on PSSC Schroth classification. So it's a CNOT type brace, okay? What brace do you recommend, CNOT or Gensigen? I will repeat something that I said in my presentation. The name plays no role. No matter if you call it Gensingen or CNOT or Sforzesco or whatever. It is how the brace is made. I also believe the same for scoliosis-specific exercises. No matter the name that you use. So I personally don't understand why there is, for some people, because it's not for everyone, let's say, kind of conflict or fight about the names. Of course, also for us, when you finish our certification, you will get a certification under a name. You will be PSSC Schroth therapist. But even having a certification or 2 or 3 certifications, this does not mean that you are a good therapist. So I cannot give you an answer, Sino or Gensingen. I can tell you both of them, they can be good, moderate, or bad braces, based on who made the brace, who is the patient, what is the correction, and what is the final result. So I cannot comment on saying this is better than the other. Also for our school, I cannot say we are better than the others. I always prefer to leave the judgment to you, that you come to our courses. What I can just tell you is that I'm really happy that in our courses so far during this year, having many times therapists that are already certified in other schools, when they come to our courses, they feel that they expanded much more their knowledge, and they feel that it is something new and really beneficial for them. So I'm happy that we have a very positive feedback. And to be honest, I love giving courses having students from other educations, because I'm a kind of person that I like discussion, I like questions, I like disagreements, but you have to justify what you do and why you do. So if you ever come to our courses, you will see that everything that we do has a justification. So I think that this is the way we have our courses. So there is going to the next question. Could brace prescribed after surgery? Yes, it can be prescribed, although it sounds quite strange to some people. I can tell you that nowadays, some surgeons, they combine operation with bracing. So some of the, let's say, most famous surgeons for vertebral body tethering, Ahmet Alanay and his team in Turkey, I can tell you that they combine VBT for the thoracic, brace for the lumbar. The concern of the surgeons is usually to save levels in the lumbar fusion, because lumbar fusion can have many times higher risk of long-term complications. So this is my answer. Of course, it can be combined. In the past, they used after spinal fusion brace for stabilization, but now is not only that way. They use it as a protocol to combine non-fusion technique with bracing. But of course, it's still early to have safe conclusions on that. There is another question, if I understood correctly, if it is only a primary thoracic curve present with minor lumbar or without a lumbar, we always do overcorrection. It's not absolutely true. You are not wrong. Sorry, just give me 1 second. I need to speak for 1 second. Sorry. I apologize for this interruption. So I said that what you asked is partly true, but not always. It means when you have a single curve or, let's say, major curve thoracic without the lumbar, most of the times, yes, you can do overcorrection. But please don't forget about the S types. S type is a proximal thoracic curve. So sometimes you have to decide minus, so no overcorrection, if you have an S type. And I think that proximal thoracic scoliosis is not well described and not good education from many other schools, to be honest. Because I think that most of the schools, they say, all right, S-type or proximal thoracic, but what are the corrections that we do? at least this is my experience from my other education and from students that come to our courses. So not always true, but most of the times what you said, if you have a clear major curve, yes, this is true. There is another question, where did the patient can stop the exercises and sessions after the marked improvement had performed? And if the patient is athlete, do you recommend to retire from the sports? There are two questions here that I need to answer. First of all, the end of exercises, it depends on many factors. Obviously, at some point, you have to stop exercises, and then your main concern is just to maintain the correction in the long term. And for this is important, the activities of daily living training, because this is a lifelong education. Then, if you have an athlete, if you recommend to retire from the sports, no, I have never asked any person, any patient, any athlete to stop what they do. Because what we know is that there is no relationship about, there is no cause-effect relationship that you do a sport and by doing this, you will develop or you will progress your scoliosis. And I believe from my experience as well, that when you have a proper treatment of the patient, no matter the sport that they do. And we usually encourage the patients to participate in sports because for the general benefits, for psychosocial reasons, not only for the muscle system. Can the patient do exercise alone at home? Obviously, it's not just if they can, they must. So don't expect that the good result is achieved only when the patient is coming to your clinic. You have at the beginning to develop a home-based program. And I think this is also a very good advantage from our school because we have plenty of exercises that can be applied at home from the very beginning. So yes, obviously they must do the exercises at home. I think that I have left only two questions to be answered, but I need your translation.
Okay, so the first one, can we get the presentation that you gave today? Is there any way you could put it somewhere?
No, obviously
Yes.
not the
Okay.
presentation for sure. Maybe what we can do is probably we will upload this video to our website, but to get the presentation itself, no, of course not. Sorry for that.
Yes. The second part of the first question,
Sorry.
is there any, just a second.
Yeah, I thought
Yeah,
that it was answered. Sorry.
it's okay, I'll find it. Okay, so it was, is there any way that we can get some kind of certificate that they attended the course tonight?
Look, this is the easiest thing to do. I mean, I can give you a certification that you just attended a course, a lecture. However, I think that this certification has no validity, and I'm afraid that maybe some people might misinterpret the role of this certification. So, no, you will not get a certification of attendance because from my previous experience with webinars, I think that some of the people, they take the advantage to say, okay, I'm certified because I have a certification and nobody pays attention on what is written over there. So I know that some of you, you might think about, your continuous education. So I think it's just almost 2 hours, so nothing to earn from this. Okay. And my concern is that some people might misinterpret what the certification will give you. Okay. So I apologize for that, but I decided no certification for this.
Of course. And the last question, how often are you supposed to do the exercises, and after what time is the improvement seen?
Again, I have to say that it is completely individualized. So, and it depends on how you define improvement. Because when you treat, for example, a patient in adolescence, the main aim is to avoid progression. And if you avoid progression, you already have a good result. So improvement is something that you need to define. Improvement is radiological, clinical, many things. However, in our school, you will get an education on how to have a proper clinical follow-up of the patient. I think this is another great advantage when you follow our education, because we spend a lot of time to educate you about proper clinical monitoring of the patient to take the best clinical decisions for them. And I have to tell you that we are a school that we pay a lot of attention to explain to you that a curve type can change and your decisions can change either as a good or as a bad result, and you have to take these decisions many times by your clinical measurements. So in our basic course, we spent almost 3 hours to explain in details for you about clinical decision making, clinical radiological measurements, and prognostic criteria. There is another question. What is my opinion on German school of the Schroth method? My opinion is very good. Also, the founder of the school, Axel Hens, is a good friend of me, one of my great mentors that I had the luck to work with him. Obviously, we have some similarities, but again, obviously, we have many differences. So, my advice, as I said, is that in every course that we do, not only me, but also my instructors, to encourage the participants to follow other educations. Maybe we are the only school that we do that, to be honest. So sometimes I'm accused that I'm too open-minded, saying that some participants, they say, oh, come on, why you are encouraging us to do other education? We came to do your education. And I say, yes, okay, but to get a better conclusion, you have to compare yourself, not me. I will never tell you that we are the best or that the others are worse than us. Of course, I can compare some things saying that we do it in a different way, and I need to justify why we do what is different from other techniques. And we have, as I said, of course, some similarities, but many differences. We are a completely, let's say, unique school with our own philosophy, with our own classification, our own criteria on how to classify the patient and how to treat them. So, my opinion about German school is that is a very good education if you want to follow. Okay. And then if you do different educations, the judgment on which one works better for you is just taken from yourselves. Okay. Hope to start PSSC in Syria as soon as we can. Yeah, me too. I hope all the same. Do we have to be Schroth therapists to access your training? No, not at all. You just have to be physiotherapist, not Schroth therapist. So there is no requirement to come to our course to have done any other education. But it's true that many times that we have participants that they have done many different educations. And I think this means something for us, that even some of the participants, they are already experienced or educated in other techniques. When they come for our education, they still feel that they learn new things and change their practice. That's really important. And I can tell you that I'm very happy that so far we have an excellent feedback from our participants, especially those that are educated in other schools. But this does not mean that you need to be certified in any other school to come to our training. You just need to be physiotherapist and you just need to apply for a course. So I think that every question is answered. We are perfectly on time. Just 2 hours was the plan for this webinar. And for those that you are still here, I think that maybe I will give the last word to Alma. Maybe you can say something to the participants that are coming for your country. I have to say that we have already planned and announced our course in Croatia. So for those that you would like to attend this course, you have to be in direct contact with Alma. So Alma, you can close the meeting in your language.
Okay, thank you for your presentation.
Ja ću govoriti na hrvatskom, pa će Hana prevesti. Mi smo u dogovoru sa Nikosom u Hrvatskoj dogovorili 2 basic kursa. Jedan bi bio od 22. do 24.3., drugi od 10. do 12.5. Znači, možete u bilo kojem terminu koji vam odgovara online odslušati basic kurs, a onda bi od 21. do 26.5. bio organiziran osnovni dio koji bi bio praktični, koji bi bio sa Nikosom, najvjerojatnije, i on bi se održavao u specijalnoj bolnici Goljak u Zagrebu. Sve informacije imaju na web stranici i to kod Nikosa i na Skolio Time.
Okay, I will briefly translate. So there are 2 parts of the course that are being held here in Croatia with Nikos. So the first part is the basic course that we already talked about. There will be 2 different times that you can attend this basic online course. You can choose whatever time fits best for you. So the first will be from 22nd to the 24th of March, and the second one will be from the 10th to the 12th of May. So you do not have to attend both of them. So this is the same basic course online, just 2 different months, whatever fits best for you. And the second part that is not online, it will be held here in Croatia, most likely with Nikos, from the 21st to the 26th of May. And the price of the course is 1,600 euros. And this is being held at the special hospital for children with neuromuscular diseases called Goljak.
Perfect. So I think that we are exactly on time. I know it's quite late for you, even later here in Dubai, but I really enjoyed this lecture. I hope that you also, the participants, you enjoyed these lectures, and maybe, hopefully, some of you, I hope to meet you in person in one of our next courses. So goodbye to everyone. Take some rest, and we'll be in touch. Thanks a lot for this organization. Thanks. Bye-bye.